So what does a predictive model allow us to do, right? So I'm going to kind of explain to you what are predictive models going to help us do. So we have coronary heart disease. There are about 8.9 million deaths in the US, in 2015. So about like 6 years ago, when you were just, 8 years old, at that point, there were just 8.9 million coronary heart disease deaths worldwide. So in your heart, you have these blood vessels, they're pumping blood. And, this is a coronary artery. And what happens in these diseases is that there are fat deposits like plaques that restrict blood flow in these arteries. So it's damage or disease in the heart's major blood vessels. And some of the possible symptoms can be like chest pain, heart attacks, and treatments. Do you want to read the treatments aloud?
Well, lifestyle changes, medications, angioplasty, and surgery.
Yes, great. So there's so many treatments that you can go through as well. Like, you can change how you live your life. If you're a smoker or not, you can change so many things. So, if you're understanding what coronary artery disease is, it's commonly caused by arteriosclerosis, smoking, hypertension, also like stress levels, high blood pressure, fatigue, chest discomfort, shortness of breath, and you can treat it with lifestyle changes, medications, or surgery. You can drop the cigarettes, stop smoking. So you can see in a normal artery, you can see these red blood cells delivering oxygen to all these vital organs in our body here. And in one with coronary artery disease, there are plaques instead that are clogging the vessels and making it very difficult for blood to be sent through. All that just makes it so challenging as well. So it's so hard. Your heart needs to pump even harder to send blood through it. It's like there's a roadblock and it's a traffic jam, and you have to really put so much. You have to really drive as fast as you can. No, don't drive as fast as you can. I mean, that's dangerous, but you really have to struggle to just get through. Like it's a traffic jam. It's so hard to get anywhere. So in our heart, coronary arteries on the surface of the heart, normal coronary artery has normal blood flow. There's nothing obstructing the arteries. It's like just smooth sailing. But in coronary artery disease, you're having a narrowing of the coronary artery. So there are these plaques that are causing abnormal blood flow. So there are all these situations that have arisen. And there's this study that's called the Framingham Heart Study. And what it's trying to do is it's trying to help identify. So it's an epidemiological study that began in 1948 with 5,209 men and women. Okay. So in this study, do you want to read about this? So do you want to read about the Framingham Heart Study?
Sure. Using decision trees to predict the 10-year risk of developing coronary heart disease.
Okay, so what is the Framingham Heart Study? Okay, so do you want to continue reading this?
It was a turning point in identifying the risk factors of heart disease and is one of the most important epidemiological studies conducted. A lot of our present understanding of cardiovascular disease can be attributed to the study. The origin of FHS can be attributed to the premature death of U.S. President Franklin D. Roosevelt in the year 1945.
And you see, great, thanks, Rex. You see, right after 1945, he died. He's one of, there's nothing to fear but fear itself, one of the great U.S. presidents. So in 1948, just 3 years after his death, they started this study as well, gathering individuals, trying to analyze, all of these things. So they've had 3 generations of participants. So over 3 generations, they're trying to characterize sort of what's happening, to people as well. So they have some information, exams, they have some genetic information about people, why is there heart disease, right? So a lot of our present understanding of cardiovascular disease can be attributed to this study. So, okay, so that's our president. So do you want to read this part here?
The president had extremely high blood pressure, which at that time was not considered a big deal. Before his presidency, his blood pressure was 140 over 100 millimeters hectograms or something, which is considered high according to today's standards. 1 year before his death, the president's blood pressure shot up to 210 over 120, which today is considered a hypertensive crisis. At that time, his personal physician was a specialist in ENT and was not a cardiologist. He insisted that the president was healthy and said that his blood pressure was no more than a man of his age. The president died of a massive cerebral hemorrhage in the year 1945, and his blood pressure was 300 over 190 on that day. The death of the President Roosevelt paints a picture of our understanding of heart disease in the mid-20th century. There was a huge increase in deaths from coronary heart disease in the 1930s, 40s, 50s, and in the 40s, heart disease was the #1 death among Americans.
Yes, thanks, Rex. So in the 1940s, it was the #1 cause of death among Americans. He's one of my favorite singers, Arjun. He was married, like he's probably in his early 30s now. But when he wrote about 3 years ago, which is really, really saddening, is that, his wife passed away from a sudden cardiac arrest, and he's in a state of shock. And they were such a young couple. So she died from a sudden cardiac arrest. So she herself was a doctor, but they didn't even know. It was a shock to him. He just said that he's in a state of shock. They just could not understand why this happened. And so it's very devastating, these sudden heart diseases. So, that's what is very shocking. And so people are trying to better understand heart disease measures that can be taken to combat it. So the Framingham Heart Study was established in the late 1940s by the National Heart, Lung, and Blood Institute, and from Boston University. So they have a large cohort. So cohorts are like groups of individuals who are studied in, when they're studying different diseases or, public health outcomes, then they take a cohort. And they looked at people between age 30 and 59 in Framingham, Massachusetts. So that's where the Framingham Heart Study came from, Framingham, Massachusetts. And they track these people for a period of 20 years. So they're doing like follow-up visits. So it's almost like every year how you see your doctor usually routinely. And it's almost like that they were being followed up for the past 20 years. So they could better understand cardiovascular disease. So the initial cohort had 5,209 patients. So they enrolled people who did not have cardiovascular disease, and they saw who would develop it within the next 20 years. So they get you early, and then they're trying to see what happens to you guys over 20 years, who ended up developing it. So every 2 years, participants would report to a testing center. So over 20 years, they did this. So do you know where an examination was conducted? So do you know how many, so if there was conducted for 20 years and they're going to a testing center every 2 years, so do you know how many tests were done around?
40 each?
No, it's over 20. Yeah, 20 years, but
10 each.
Yeah, around 10. Great. So around 10 experiments. So these patients were examined and their health information was updated. So 2 years, right? Because this is a test and people have lives going on. They don't want to keep disrupting them. So they gave it every 2 years and they were given questionnaires. So they updated behavioral information, exercise, smoking habits as well. So the data collected from this study allowed for a better understanding of the risk factors of heart disease. And then medical interventions then took place based on the findings of the Framingham Heart Study. So the idea is figure out from like these 5,209 people, try to figure out why did some people develop heart disease and others did not. So do you want to read some important milestones of the Framingham Heart Study?
Sure. Smoking was found to increase the risk. Cholesterol and high blood pressure increase the risk. Physical activity, high levels of HDL, cholesterol, lifetime risk of developing CHD was higher in men than women. Obesity is a risk factor for heart failure.
Yes, thanks, Rex. So you can see that some of these things, back then, a lot of people were smoking. They didn't know why that it was bad. So these studies can show that smoking increases your risk of CHD. So if 80% of the people who ended up getting coronary heart disease were smokers, then they can say, hey, if you're a smoker, then this increases your risk of coronary heart disease. So they are analyzing the data and they're trying to figure out why do certain people have a higher risk of heart disease than others? And maybe physical activity decreased that risk, high levels of high density lipoproteins increased it. And men had a higher risk than women of having coronary heart disease, and being obese is a risk factor. So, in 2002, they had the second study was started with the other individuals between 30 and 59, was started in 1971, after 20 years. And then in 2002, the third generation cohort started. So I think we're almost finishing up with the 20 years follow-up, right? Because this is 20 years will be 2022, which is just next year. So we've conducted the third study as well. So there've been so many studies, 2,400 studies written using data. Every people are analyzing this data to figure out what is the risk for heart disease. So this Framingham Heart Study has contributed greatly in reducing mortality rates associated with coronary heart disease and many clinical misconceptions about heart disease. That means it cleared up a lot of things that people did not know. So if you wonder why did people know or realize, that smoking is bad, or that, how does science develop? How do these innovations and treatments and drugs develop? A lot of that comes from people conducting these clinical studies. And these are things that today we might be like, oh, that's common knowledge. Yeah, of course, smoking is going to increase your risk of coronary heart disease. You guys learned this in health classes, for instance. You guys learn all those things. Exercise is great, not just, So these things we scientifically prove that these are. Have you heard of Mythbusters before? Like Mythbusters. So I think it was kind of big in my time when I was growing up as well. And then what they try to do is they try to conduct scientific experiments to prove or disprove certain myths that, So how hard is it to find a needle in a haystack? Can water dripping on your forehead really drive you nuts? These are the kinds of questions, myths, and urban legends that are put to the test in this humorous series that seeks to find out which myths are true and which are not. So people are trying to conduct experiments on those and figure out which myths are true, which ones are just made up, So they conduct these experiments here. So similarly, from this data, people figure out so much information that they can use because they have people, during their lifetimes, over 20 years, they're having people who are healthy and who suddenly develop cardiovascular, means health-related disease problems. And why is that the case? Why is one of my favorite singer, Arjun, why did his wife die when she was almost 30? She died. Like, why did she die all of a sudden from a sudden cardiac arrest? And she is a doctor, so she might have also known some of the signs. So people use so this is pandas, this is in Python. So people have been loading in all this public data from the coronary heart disease, from the Framingham Heart Study. So you can see what they collect is like gender, age, education level. Are you a current smoker? Cigarettes per day that you have, blood pressure medications. So if it's 0, you don't take any medications, and this says the number of medications you're taking. Have you had prevalent stroke, prevalent hypertension? Do you have diabetes? So they're collecting lots and lots of data, and they're trying to figure out, they have 3 sets of studies. The first one conducted in 1948 and 1971, with a bunch of people, like they follow up over 20 years. And now the other one was in 2002. So they have demographics, like, do you have a high school education, high school diploma, GED, college, or degree in general. So you're a current smoker, medical history, do you have stroke or not? No prevalence of stroke, or have you had a stroke? Prevalent hypertension, diabetes, total cholesterol. From the first physical examination, they have your total cholesterol, systolic blood pressure, diastolic blood pressure, body mass index, heart rate in beats per minute, glucose level. And then they do some exploratory data analysis where they look at all these individuals in the Framingham Heart Study, and they try to figure out how much education each person has, where 4 is some degree, 3 is like college, 2 high school. That means you dropped out of high school. That's what 1 means. So these people here, a lot of them were high school dropouts. And then the second one, these people completed high school. And these things can also change by cohort. So maybe back in the day, when college, high school was enough, you didn't need to go on to college. Now today, they're arguing that even undergrad education may or may not be enough. You might have to go for a master's degree. So trends have moved towards not just if you've graduated high school or not, but if you've finished college or not. Like that's, so those trends may change. So most participants seem to have some form of high school education. See, most of them have some. That's what the first one is saying. They've gone to 9th or 10th grade. They may just have your education and have dropped out, right? A fewer number of them have a diploma and went to college, and very few have a degree. So this would be like college dropouts, and this is like people who have a college degree. And then you can see that these are people who, cigarettes per day, smoking was said to increase the risk of coronary heart disease. So they're trying to figure out in people, so this is cigarettes per day, and this is 10-year coronary heart disease. So this is measuring if you develop coronary heart disease within 10 years. So, and the 10-year risk of coronary heart disease. So those who had a 10-year risk of coronary heart disease, they tended to smoke more cigarettes per day than those who did not. So do you see that? So those who don't have a risk of cardiovascular disease tend to smoke less than those who did. So this is cigarettes per day. So between 0 and 12. And these are just ways to summarize the data. We have a bar here that shows the average, and this just shows the typical range within it. So this is like the average. And then you can see the 10-year CHD as well. So these are just different metrics by age, diabetes, total cholesterol. So these are all variables, body mass index, blood pressure medications. So do you see that the number of blood pressure medications, that can sort of predict how high your blood pressure is, right? So if you have high blood pressure, you'll be taking more medications. And the people, so 10-year CHD means that if it's 1, what this is saying is that you have risk 10-year risk of CHD. So this one is just saying this is the worst outcome. This just means that you have a 10-year risk of having coronary heart disease. That means you're on the path of having coronary heart disease. And this one means that you're healthy, you're good. So do you see blood pressure medications? So do you see that this is so much lower than this? Do you see that?
Yeah, I see it.
So having more blood pressure medications really increases your risk of heart disease. So people are fitting different models here to try to figure out, well, what is our risk of coronary heart disease? So that's sort of what the data I was looking at, for instance. Okay, sorry, just done. So I was looking at a cohort that had about 4,568 patients. And so this is the patient ID, gender, systolic blood pressure, diastolic blood pressure, serum cholesterol, age, body mass index. And we have the actual outcomes for these people, like did they actually end up developing coronary heart disease or not? So the goal is to try to figure out patient outcomes, use the genetics, the gender, the race, the age, family history, environment, exposures, lifestyle, are they smoking or not, try to figure, look at therapeutics and try to figure out, what are the risks of coronary heart disease? Utilize all this patient data. Do you see this type of data on patients? We have the ID. This is not important, but we have the gender, male or female, blood pressure information is here, cholesterol, age, body mass index. And then we have the actual outcomes. So do you see that? Like how that is made?
Yeah.
And what people come up with is a predictive model that takes all that data and they can try to figure out, okay, have you ever seen something like this, like an origami?
Yeah, I've seen it.
Great. So whatever you pick the first time around impacts what then based on that, it's like something with your hands. Like it's very cute. You can make it with a sheet of paper. So based on those outcomes, you then have to pick another number and then you get a certain outcome in the end. So similarly, there's something called a decision tree, which is it looks just like a tree. So so this is learned from the data. This is one of the types of models, predictive models out there that is learned on data. So based on this model, you can look at the age and look at the gender. So where you are is you are less than 45. You are a male. Do you smoke? I'm going to say no, you do not smoke, right? Then I'm going to look at your total cholesterol here. If your total cholesterol is less than 225, you have a low risk for coronary heart disease. Do you see that?
Yeah, that's it.
So you go here because of your age. The first question is, what is your age? If you ask a bunch of questions by someone, right, and then you can change it, right? What is your age? Is your age? So then you'll say my age is 14. Then say 14 is less than 45. Okay, I'm going down this branch. But in another like 31 years or so, 32 years, you'll be going down this path here, right? So when you're 45, the question will be, okay, so you are a male. So when you're 45 and up, then they'll ask you, okay, so you're a male. Okay, are you a smoker? Yes or no? So if you say I'm not a smoker, then they're again going to ask you your total cholesterol. If it's less than 225, you're low risk. But if you say, hey, looks like my cholesterol went up, actually, it's greater than 225. Then they're going to take your blood pressure. Have you ever gotten your blood pressure taken? They put the stethoscope and, then let's say that your systolic blood pressure is greater than 135. What will they predict for you? And so you're here and your systolic blood pressure is greater than 135.
High risk?
Yes, they will say that you are high risk. And then hopefully that won't be the case, but then they'll say, hey, Rex, looks like you're high risk of coronary heart disease. We have to do something. Maybe what you should do is figure out how we can lower your systolic blood pressure, because if it gets lower, like less than 135, you have a low risk. So that's how they can tell you the treatments to take. So this is a tree, and this tree is learning from this type of data. And these are just a few of the columns. There are more columns in this data set, but I was just showing some of them. And people use whatever data variables they want and they put it into a model, or a tree can be one of them. Maybe instead of looking at gender, blood pressure, cholesterol, smoking, I can also look at education. Maybe I can also see, okay, like, have you gone to college or not? I can make different trees, but it is a tree because you go down along that. It's like a set of questions that you ask. Okay, so okay, so are you, so it's like if you're trying to figure out your chance of getting into a certain college, your guidance counselor will ask you, okay, so have you taken the SATs or ACTs? If so, okay, what is your score? Okay, well, if it's not in that range, hopefully you look at really good scores, touch wood. But let's say that if it's not in some range, then they'll ask, okay, well, do you do this instead? Like, what is your cumulative GPA, right? So they ask you a set of questions based on where you are, right, at each step. So age is the most important one determining, these two different baby trees here. Do you see that? Like if your age is greater than 45, you go down this tree and you can ignore this. If your age is less than 45, then you go down this tree. And then the next question is your gender. So do you see that? This is a model that you can learn from the data. Another thing is I was building another predictive model that was using serum cholesterol level. So serum cholesterol level is, the levels of cholesterol in the blood, the total amount. It can be high density lipoprotein, low density lipoprotein, triglycerides in the blood. So it's a type of body fat, right? And this serum cholesterol level is the amount of total cholesterol in that person's blood. So I tried to build another type of predictive model that was using serum cholesterol level. And it says that, hey, if your serum cholesterol is less than 200, so it's measured in mg/dl. If it's less than 200, then you're in a good spot. What happens if it's between 200 and 239?
It's high.
Yeah, borderline high level of cholesterol. And then if it's really high, it's 240 and above. And then people recommend, how do you lower this cholesterol? You can eat healthy, avoid smoking, drink alcohol moderately, be more active. So people are trying to figure this out. How do we make these predictions? So what if somebody comes back with 100 as their blood serum cholesterol level? What is their risk of having that? So one of the things, it's pretty low. Yeah, that is true. One of the things that I did is I had fit these models to sort of predict. So this is a model that I had created that is sort of based on a logistic regression model. So if what this is this is your serum cholesterol level is 100 and 100. So I fit a model, and that model essentially is saying the following, is making the following prediction. It says that, hey, serum cholesterol level So this is the model that I built, and so this is the same thing as so this is the same thing here. This is an E. This is E is a special number. This is a logistic regression model. So what happens is that we have probability of having coronary heart disease between 0 and 1. Yeah. So if it's 0, what does 0 mean? Like, what does it mean if there's a 0 probability of coronary heart disease?
Means there's no way you can get it.
Yeah, awesome. And this was the data originally. The data was actually like this and this, because what we have is we actually have outcomes. We have the serum cholesterol level, SCL. So what this data actually involves is it just involves these two spots. It involves serum cholesterol level, and it involves your probability of, so whenever the probability of CHD is 0, that means that the patient actually did not have coronary heart disease, which is CHD. Whenever it's 1, then they have coronary heart disease. So I'm just taking the serum cholesterol level and the probability of CHD. So the y-axis is the probability of CHD, and the x-axis in this is just, so if we look at the axis, so this axis here, this is this SCL level, serum cholesterol level, and the y-axis is the probability of heart disease, of CHD. So do you see that? Like, that's what the data is. So what do you say? So this either is 0 probability or 1 probability here. That's sort of what it is, right? Like, that's what the data looks like, the data that we're learning from. It looks like it's either 0 or it's either 0, which is here, or it's 1. Do you see that? Like, for the actual patients?
Yeah.
It's either 1 or it's 0. Because if you actually have coronary heart disease, then you are up here. And if you don't have it, you're down here. So that's the data. So what the data ends up looking like is it just ends up looking like it ended up looking like, you know, like these are people who don't have it and these are people who have it, right? Oh, wait. So imagine this is on a straight line. I'm not very good at drawing. So this is all a straight line here. Do you see, like, there could be some people with really high cholesterol and there could be some people with even low. Do you see that this is sort of like how it looks? And this is all like one line going across. And this is also, this is one line, and then this is also another line. So do you see that? Like this is one line and one line. And the idea is that we have the serum cholesterol level, so people who do not have coronary heart disease and people who have coronary heart disease. And we're trying to figure out how can we represent this information so that we can predict someone's risk of coronary heart disease given serum cholesterol levels. So we're trying to figure out how can we draw some model that can predict some probability of coronary heart disease. Do you see that? Like we may struggle to do that, but there are models out there that can try to figure out what is the relationship. You see, we can have not just 0 and 1 outcomes, we can have some kind of relationship where this, see, because it's just 0 or 1. Either you have it or you don't have it. And these are patients, we know the outcomes for them. But maybe we want to predict, hey, you have a 60% chance of coronary heart disease. Or we want numbers between 0 and 1. Not just 0 and 1, we want, because of the probability, the numbers can be between 0 and 1, right? We want to be able to get all these values in between as well. And see how changing your serum cholesterol level helps change your risk of coronary heart disease. Do you see that? Rex, do you see that? Does that make sense to you? Any questions?
I think I get it.
Okay. So all they're trying to do is you're trying to fit a model that can give you not just 0 and 1, but sort of tell you the probability. So this is a type of model that you can make. It's called a logistic regression model. And this logistic regression model, it looks like an S, and it's sort of smooth like an S as well. So what's happening is this model is starting out at 0, and then at some serum cholesterol level, it's picking up the risk of having coronary heart disease. So at this level, maybe your risk is like 20%, you know, at the serum cholesterol level. So it's picking up. So as your cholesterol level, as you're moving along this, you're moving also along here. So a way to see that is that if your serum cholesterol level is here, then your risk for coronary heart disease, if it's at this level, it's this much. But if you go out a little bit, if your serum cholesterol level rises a bit, then what do you notice?
We find out. Wait, which one are we looking at?
So if your serum cholesterol level is here, right? Like let's say that this could be like 90 and this could be like not 90, but this could be like 150 and this could be like 200, right? You see that like this is serum cholesterol level, right? So you have a certain serum cholesterol level. And then what you do is you jump. So this purple is a predictive model. It's a prediction model that you can learn. Just like the decision tree I was showing you that you can learn from the data, you can also learn a model like this using any features that you want. And you can say for a given serum cholesterol level, like I want to plug it into the model, and the model, so you go from this level, you go up this chart here, and then you see what the probability is. Like, do you know like y equals mx plus b, like, you know, y equals 3x minus 2, minus 4 or something? You know how you can have, for any situation, you can have y equals 3x minus 4, And you can see, do you see how the X and Y, do you see as I'm moving this, the X and Y values are changing? You see like this blue thing where the arrow is, you see it? No, it's kind of tiny, but as X is changing, how is Y changing on this graph? As the serum cholesterol level is increasing from here to here, then we just go for the serum cholesterol level and we go to the model that we learned, a logistic regression model. And that model can look like this. This is the way that the model looks like. It looks like E to this number divided by 1 plus E to this number. And there's code, there are these methods that learn it for you. It's called a logistic regression model. There are algorithms out there where you just can put in your data, put it in a logistic regression model, and it's going to learn this formula for you, where you take any level. This can be this is your X value, your serum cholesterol level. And it's going to figure out what is the probability of you having, this coronary heart disease. That's what it's trying to learn. So as your serum cholesterol level is increasing from here to here, so for a serum cholesterol level, this is your probability of coronary heart disease right here at this point here. But if it increases to this spot here, then you go up here and you see in both directions how. So if you go up from here to here, then you also see how much your heart disease risk has increased. Do you see that? Like as your serum cholesterol level has increased from here to here, your risk of having it has gone up. So logistic regression allows us to predict the probability of having this disease, so that you can figure out, maybe you don't have it yet, but it wants to figure out what is your risk of having it. So that's what this model is trying to do. It's trying to figure out the probability the patient has coronary heart disease. You take in the serum cholesterol level, and it's trying to predict the probability that a patient will, or a person will have coronary heart disease. So this is a model that is learned from the data. And in this case, these, like as I showed you, the outcomes, people who didn't have it and people who have it, you see these black dots where they're really, really dark is where there are a lot of patients. Each of these circles, each circle represents a patient, a sample. Like each of these represents a sample, 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 sample. Each of these represents a sample. So this is the logistic regression model. It predicts the probability of you having coronary heart disease given a serum cholesterol level. So if I plug in this equation here, if I say, hey, I have a 100 serum cholesterol level, that's the serum cholesterol level that I have. What is my risk of having coronary heart disease? I took this measurement, serum is the blood. Remember we were talking serum is the blood cholesterol. It's in your blood. So, a person's pricking themselves and they have 100 is right here. So it should be desirable level. They still want to know, what is my chances of coronary heart disease? So I put it into this model here. I put in 100 for them, 100 here. And all I do is I just calculate the numerator, which I get to be 0.15102, and the denominator. So you can just use this. This red is the model that is learned. And this E is 2.71. So the original model is E divided by 1 plus E. E is a special number. So all this allows me to do is to just predict from a serum cholesterol level that I have a certain probability of having coronary heart disease if I have 100 as my serum cholesterol level. So what is that probability that I have coronary heart disease if my serum cholesterol level is 100? So what is the answer?
Would it be the 13%?
Yes, awesome. So if my serum cholesterol level is 100, then I have about a 13.14% chance of coronary heart disease, which can be relatively low, right? So now what if instead at this level, instead of being 250, what if this is 100? Like let's say now that it's 250. Like what is the risk of me having coronary heart disease? So let's slash out this over here. Instead of being 150, It's now, 100, it's now 250. That's my new thing. So this 250, like where is it? And in this typical chart?
On the red.
Yeah, it's like probably here, it's in the high level of it, right? So we went from 100, which is probably somewhere smack here. And then we've gone to like 250, which could be something like right here. So what is our risk of having it? So all I do is I just take the same model again and I plug in. So this was the predicted probability of coronary heart disease from our model. You know, it looks like this, E over this, where E is just Euler's number. It's just 2.71828, right? It's just some natural number that you learn more in math class, but it's just, this is an exponent value. You know, you just multiply, 0.0084, you multiply this number by some level of serum cholesterol, which is here is 250. And then you add negative 2.74 to it, and you get some number in the numerator. So if you do this for 250, if you plug in 250 here, the numerator ends up being, the exponent ends up being negative 0.6178107. You see that? Like that's what the exponent ends up being. I still had to finish solving this. How about you? Can you help me solve this with your calculator? Do you have a calculator with you?
Yeah, I'm getting it.
Wait.
It's 0.35, 35%.
Oh, so this becomes 35%?
Mm-hmm. 35.07.
Okay, 35.07%. Okay. So this is, okay, thanks, Rex. So this is what it becomes. So you see how you can just take this number, raise it to this negative exponent, and then to the numerator and the denominator in logistic regression, they're almost the same. Do you see that? Like this is pretty much the same here, but except for what?
1 plus.
Yes, awesome. So that's typically like the way that it works. And it's similar to an f of x problem, like f of x equals, it's very similar, like f of x equals like, like 3x minus 2, like very similar to that, except here, the f of x is a predicted probability. The values are between 0 and 1. So for you to get values between 0 and 1, it has to look something like this, where whatever the numerator is, the denominator is 1 plus that number. So it'll be between 0 and 1 that way. That's how because the probability is between 0 and 1. So to get those values, this logistic regression model was designed by some mathematicians and statisticians. They designed a model that can help you predict some probability of some outcome. Probability that you have coronary heart disease, probability of you getting into this college, probability that it's going to rain tomorrow, probability that the market will go up, the probability probability that you will have COVID, right? Do you see what I mean? Like there's anything that probability that the coin toss will be heads, for instance. So probability that you're going to win this game. You know, anything, it's like either you win or you lose. Whenever there are two categories that are involved, either you win it or you lose it. So do you see that? Like you can either win or you can lose, and there are two outcomes: probability that that this fruit is rotten, probability that this baby is happy, or the baby's either happy or sad, right? For instance. So many different outcomes, and this allows you, so you see that when you plug in 250 here in the numerator, it becomes just a number here. It's just you multiply this by this. And whatever this is, this part is learned from the data. This equation is learned from the data that you give in. So this will depend on the data that you give into it. You learn this model, you learn this formula from the data. So this is serum cholesterol level, and for using that to predict coronary heart disease. And you can see that when it's 250, the risk goes up to 35%. So that's so much higher. Then if my serum cholesterol level is 100, the risk is just 13%. But if it rises up by 150, the level rises from 100 to 250, the risk has gone up to 35%. Now, Rex, this model may or may not be accurate, right? But this model is predicting a probability. So you could ask me that, hey, like, are you also wondering, like, why I only used cholesterol? Why not age? Why not gender? Are you wondering that?
A little bit.
Yeah, so Rex, the answer is sometimes there's no right answer. So right now, and I'm also doing research as well, and professor often tells me that sometimes there's no right answer. You have to try it and see what works. And in data science too, there's like sometimes there's no right way. I mean, there are some wrong things you can do, of course, but there are different methods that you can do to try to get to an answer. So maybe I just wanted to make something very simple. Now this has an advantage that it's super simple. You just need someone's cholesterol level. You just need them to just maybe prick themselves and come up with that number, and it can predict some risk for you. It's better than you just guessing. But you know, like, it's better than you guessing. Like, it's so much better that you know, like, what is your risk. But this was just one model. I used serum cholesterol level, and I had the people's cholesterol and their risk for, this is the probability of coronary heart disease. These are people who don't have it. Each of these round circles is people who, you know, is a sample. And wherever it's black, that means that there's a lot of overlap of sample. That's why it's black, because all the overlaps are overlapping. Do you see that? Like, it's all overlapping. That means that there are a lot of people here and here. And you can probably see some split here, where there's some people with some low serum cholesterol who don't have it, but some people who still have it too. So it's sort of a little bit unfair that some people with low cholesterol don't have it, while others who have low cholesterol can still have it. So there are certain other things that could also predict it, right? Like when there's somebody over here who has very high cholesterol, like higher than many other people who have it, but this person does not have it. You see how that can land up? Like, this person has very high cholesterol, but they still don't have coronary heart disease. Maybe this person happens to be a young female. Do you see that, like, females were found to have lower risk, and maybe the age as well is much younger? So this was a simple model, but I can also have a more complicated model too. I can have a model where maybe I want to include all 6 variables. For instance, I want to include body mass index, gender, serum cholesterol level, age, systolic blood pressure, diastolic blood pressure. Do you see? I can try to incorporate all of those. I can't really visualize the model anymore because now I have so many variables there that it's hard for me to visualize all of them. But what you can see here is, so I'm showing you 2 at a time. I'm showing you the probability of coronary heart disease given body mass index for a given gender, you know, male, female, right? I'm showing that to you here. It's a 3D plot. Have you learned about 3D plots?
Not yet.
Okay, all it is it's just like, it's just basically like f of x comma y, which is the same thing as like z equals and like 3x minus 2y, for instance, just 2y. So if I know like a certain x, like if x equals 5 and y equals 4, then what will f of x equals 5, y equals 4 give me? What will that be?
7.
So it'll be 3 times 5 minus 2 times 4, which is equal to 15, minus 8, which is equal to 7. Like you said, great job, Rex. So you actually know it, right?
Yeah.
So that's great. So like this could be like one of the two variables, for instance. And if we instead change y to being like 6 and 6, then what would this become? This would be 15 minus 12, which is 3. Do you see that? Like so when one variable changes, the other one also changes. Does that point make sense to you? So that's
Yeah.
for 3D. But when we have so many more variables, so I could only show 3D. So each time I just randomly chose like 2 variables at a time and showed the probability of coronary heart disease and how it changes. And here would see serum cholesterol. And now if we also have age, we can see if your cholesterol is going up and your age is also going up too, your risk of coronary heart disease. So this is actually a 3D point in space. This has height and width. So it's kind of hard to visualize, but this thing actually has height. So this thing like is mapping to like this part here and probably this part here. Do you see that? Like it maps to a serum cholesterol level of the value probably, or something like that. I'm also bad with 3D, but you can see that this value up here is actually in space. It's actually in space. So you can see as your cholesterol is increasing and your age is going from 30 to 70. I mentioned that they were taking people from, between 30 and some age in the 50s, and they were following them for 20 years. So the youngest age is 30 here. So you can see that this thing is like kind of going up here. The model, this is what this is how it looks. These are the data points. But I can't visual. So that's for like serum cholesterol level and age. I was trying to show like as many as I could, but I can only show 2 predictive variables at a time, like blood pressure, systolic and diastolic. And these are the actual data points here. And this people is a model. A reason is because you cannot, once you have more than 2 variables. So here we just had serum cholesterol level and heart disease. So we can visualize it. It's very simple to visualize. That's the advantage of using a simple model. You can see this red curve very easily. But now that I have, if I was just choosing 2, like then it also looks complex. But if I have 6 variables, gender, body mass index, age, serum cholesterol level, diastolic blood pressure, systolic blood pressure, it becomes so much harder to visualize these results. But the idea is that I showed you that you can have a predictive model that can have whatever variables you want, Rex. You don't have to go with serum cholesterol level. If you get this data and you want to see how having more education changes your risk, your predicted risk of having heart disease, that's what you can do. I think that's an advantage over this decision tree here. I mean, right now this just says low risk or high risk, but that could mean anything, right? Like it just says low risk or high risk. But do you like the probability? Do you like that when it predicts your chances of having it? Do you like this type of approach where you have a prediction?
Yeah.
Yeah, great. And like these are the types of apps that maybe like, all these data companies would be collecting on like SAT scores, ACT scores, GPA, cumulative GPA, weighted GPA, extracurriculars, like all these different things, like number of volunteer hours, all this stuff that they're collecting, for instance, to try to predict your chances of getting into a certain college, the probability you'll get into this college or not, like of your dreams. So they're trying to figure that out using data, and they can use a logistic regression model like this. Logistic, all that's doing is it's helping. It's basically of the form like it's of the form like e to some number, e divided by, maybe I should write it. Let me try drawing it. So it's usually of the form e to some number divided by 1 plus e to the number. And that's like our logistic regression gives you a predicted probability of it's just giving you a predicted probability of CHD, for instance, or getting into a college, whatever it is that you're interested in. It's giving you the predicted probability of that. Does that make sense to you? It's and the numbers, whatever it learns, you see that now when I include all these other variables, these are predictors, gender, body mass index, age, diastolic and systolic, then now systolic blood pressure, there it's gone to being 0.006749. That's what the model learned before now. But before, in our simple model, the what was the number instead in front of serum cholesterol level? What was this number? Yeah. So before, what was in this equation? Let me just copy this here. Maybe this will be a little easier to compare. So for the simple model, for serum cholesterol level, what do you see what was in front of serum cholesterol level? What was this number here?
0.0084.
Yes, and now in this complex model, what the number is instead 0. So it changes from this number to 0.006749. That number changed. And the y-intercept also changed from -2.74 to being -4.72. Do you see that?
Yeah.
So basically, whatever you'll get is going to change based on these predictive models that you're using. And you can use, you don't even need to use all 5 of them. Maybe you want to come up with, maybe just you want to use gender and serum cholesterol level. You can build a model on that too. So there's no right or wrong answer per se. You can try any approach. And that's why there are people out there who come up with so many different approaches to make these predictions. What is it? Like, how can we predict? What is the risk of cardiovascular disease? Do you see that? Like any of these models, it depends on what you want to do. And you can do this model, logistic regression, you can use a decision tree. You can even use a neural network, which is what we'll be learning. You'll learn about in the project about neural networks as well. You can use a decision tree instead with these variables to figure it out. So whatever you try to do or you want to do can really change. And to help you kind of learn that as well and play around with that, I've actually put up 2 videos as well. I'll share the link with you to kind of show you how predictive models can help you make predictions. So you can see how we can encode this complex logistic regression model. How can we encode this information? You know, this intercept here. How can we encode this gender value? This body mass index, age, serum cholesterol level, how can we encode all of that into a function that we can then use to predict the probability of having coronary heart disease? For Santa Claus, for me, for instance, how can you use the complex model? How can you use the simple model? A simple model is so much easier to code up too here. Like, how can I express the same formula in a simple model? And for the decision tree classifier, how can I represent this same decision tree here? How can I represent the risk of coronary heart disease, where low risk of CHD is this low risk over here? So I have a few videos in Python then that you could watch to better learn this. But does that make sense? So whatever model we're making, and it's also based on the data. That's why for the project, the more data that you collect, the better the model will be able to learn the relationships. Like instead of having 5,000 people or so for the coronary heart disease, if we had like 10,000 people, that we would see people with even more situations and our results would be even better, right? If we could, if they had the funding and everything, they would want to collect as many people as possible. If they had even more funding and more people that could enroll in that, then they would want to collect so many people. Do you see that?
Yeah.
So that's what a
Makes
predictive
sense.
model is. It takes the data and tries to learn something. And there's no right or wrong way. There's so many ways you can go about doing this, so many different models, so many different approaches. I think that this person also had, I think, let me see if I can pull this up to you. So this is another example as well, using the heart disease Framingham Heart Study as well. This is on Kaggle.com. They have a lot of data sets too. So they're trying to use Framingham Heart Disease and come up with the machine learning model as well. So will a patient have a 10-year risk of developing a cardiovascular disease? So that's a 10-year CHD risk that I was talking about. So they do some exploratory data analysis. So what that's meaning is trying to have an understanding for the data, like how many people are educated in coronary heart disease, like what are some trends that you can learn from this data. So, this is the problem here. So are you able to read the problem?
The World Health Organization has estimated 12 million deaths occur worldwide every year due to heart diseases. Half the deaths in the United States and other developed countries are due to cardiovascular diseases. The early prognosis of cardiovascular diseases can aid in making decisions on lifestyle changes in high-risk patients and in turn reduce the complications. This research intends to pinpoint the most relevant risk factors of heart disease, as well as predict the overall risk of using logistic regression and data preparation.
Great, thanks. So they can use logistic regression, to predict the overall risk, a probability of that. So it's publicly available, and it's from an ongoing cardiovascular study on the residents in the town of Framingham, Massachusetts, and they're trying to predict, will you have a 10-year risk of future coronary heart disease? Like, within the next 10 years, are you going to have like a high risk of having coronary heart disease? So it provides patients information, over 4,000 records. That means the number of individuals that it gives, and 15 attributes. So each attribute is a potential risk factor, like your age, your gender, your smoking, as well. The demographic, behavioral, and medical risk factors too, like your gender, age, education, how we were seeing all of these things, one means that, in 10 years, you have a high risk of CHD, at this rate, within 10 years, you probably could die from coronary heart disease. And 0 means you won't. So those are the predictions. So we have the actual outcomes for the people. We actually know for those people what it is, but we're trying to figure out how we can learn. So we know like which patients had a 10-year risk, because we're measuring every 2 years, we're measuring their information. We know like which people actually ended up having heart disease and which people who did not. And we're trying to learn how can we come up with a predictive model that will allow us to learn the information here, figure out something that can happen inside the body to trigger that risk of CHD. In some ways, it's kind of interesting to me, these types of things too, because you're trying to figure out at some level, how can we predict the risk of coronary heart disease? People are looking into the DNA level as well. Like, is there some genes maybe that can help? Can we take people's DNAs and do all the analysis on cardiovascular health? Can we look at, but what we have is we have patient level data here. We have like, systolic, diastolic blood pressure. We have cholesterol, but the people who also collect their DNAs and are trying to figure out what happens at the DNA level, for people who have CHD and people who don't end up having CHD. The lifestyle, we collect that information. We have all these things and we're trying to predict their outcomes, like trying to figure out what is happening inside them. And there are different levels that we can go at. We can look in the DNA and try to figure out what are risk factors, what genes, can we figure out from the genetics if someone has a high risk or not. We're also looking at like other things, like we're looking at education, we're looking at gender, because remember, one of the findings is that males have a higher risk of CHD, of coronary heart disease, than females. So we're trying to figure those things out. How can we predict this? And this is in Python. They have so many different, they have a decision tree classifier. That's the tree I showed you. They have all these types of things. When you load in the data, you see for each individual, male, I think 1 means male, 0 means you're not a male. Current smoker, 0 means you're not a smoker, and 1 means you are a smoker. So these are binary. Remember binary, like a Boolean, like boolier, like that's like a Boolean. It has 0, 1. 0 often means false, and 1 is true. So if for current smoker, 0 means you are not a smoker, and 1 means you are a smoker. That's how you can interpret that. And male, the same thing for male. Male is 0, then that means you're not a male. 1, it's you are a male. Prevalent stroke, the same thing. Those things that are 0 and 1. Diabetes, do you know what diabetes 0, 1 means?
You do have it?
If it's 1, you have diabetes. If it's 0, then
You don't.
Yes, thanks. Great. So there are all these variables out there that you can use. So what I chose is I chose gender, age, I chose body mass index, BMI, I chose systolic, blood pressure, diastolic, total cholesterol is the same thing as serum cholesterol. So it's the same thing. I chose those. And then I also looked at the 10-year CHD. I didn't look at the glucose or the heart rate. I didn't choose that. But you could have also chosen all of these things together. But you see there's some missing information, NAN, for some people, we don't have their glucose. But this is just 10-year coronary heart disease, where if it's 0, they did not have coronary heart disease risk. And 1 means that, yes, they are high risk of having coronary heart disease in the future, because those are the patients who ended up getting CHD and dying. So these are all the data, and we're trying to figure out, can we predict so that in the future, Rex, like if you're going to see the doctor, for a checkup, the doctor can put in your information into a model, make some prediction, like some little robot is going to come back and tell you, hey, Rex, based on the results, a little robot will come back and say, hey, Rex, based on all these results, like for instance, if it's SCL, serum cholesterol level, this is also total cholesterol. Based on the results, hey, you have a 13.1422% chance, based on your SCL level, your predicted risk of having coronary heart disease, within 10 years is 13.14%. Like that's what this robot will tell you. This robot is essentially learning. It's essentially learning this model and just plugging in numbers for you, like a calculator. And then again, I'm kind of teaching you. I have a video where I'm teaching you how you can program this little robot calculator, that little cute little robot that's telling you your predicted risk of coronary heart disease. You can program that using Python as well. You can just put it in and you can keep changing it, So I have a video, which I'll share with you too. But based on that, you can do some exploratory data analysis where you're looking at how, like the samples that we have, what are the typical body mass index values? What are the typical numbers of BP meds? We have a lot of people who don't have BP meds, it's 0. And then this y-axis is the number of individuals out of around 4,000, a little over 4,000. These are the number of people. So the y-axis for all of these is the number of human samples. That means the people, number of people in the study. That's what all these y-axes are measuring, number of people. And then you can see the age buckets here. You can see the age tends to be really concentrated in the 40s to 50s. You can see that a lot of people did not have 10-year coronary heart disease risk. Few of them had it, around a little bit over 500. So this is what I mean by exploratory data analysis. You can also see cigarettes per day. It seems like a lot of people were non-smokers, but some people were smoking. And current smoker and non-smoker as well. I mean, smokers and non-smokers. Blood pressure. We have a lot of people who don't have diabetes and few that do. So what does this mean here? So what is this measuring? This bar.
Is that one the males for 2004?
So this is male, when the variable male is 0. So what does it mean when male variable is 0?
That means they're female?
Yes, yes. So what is this height telling you?
So there's 2,400 females?
Yes, the number of females in the data set. So they just usually choose one, male or female, because it doesn't make sense if, the person is not a male and they'd probably be a female, like biologically, right? Like, for the most part, right?
Yeah.
I mean, there are like some transgender as well, but for the most part, like, biologically, like, that's what they typically do, like male or female, right? But then we also have prevalence of hypertension. If you don't have hypertension, that's with the zeros. These are binary. So that means that you don't have it and the 1 means you have it. So these are all corresponding. And these are the serum cholesterol, the total cholesterol, the SCL that we were looking at. So what you can see here is that these are just the same variables here. We're just doing some exploration. It's just like we're going like window shopping. We're sort of seeing how does our data look, because we just need to have some idea, like this, everybody's curious when you have a set of data on these people, you're curious, hey, like how many males and females did you have? What is a typical blood pressure? How many cigarettes a day do people actually have? You might be curious, right? And this gives you some ideas for what you can think of for variables. And then they try to figure out which features are correlated with each other and which are correlated with the outcome. So people are then looking at correlations. You'll learn about that, but what correlation means is like how strongly, a predictor, like how connected is education. So we're looking at all these variables and how they are impacting coronary heart disease risk in people. And we're trying to look at, like, does being male and does age, does gender and does age, do these two variables have a similar behavior with each other, in terms of influencing cardiovascular risk? Or does systolic blood pressure, so when you take your blood pressure, the doctor measures systolic, or even nursing assistants. So the systolic, and then there's diastolic blood pressure. So, when you're getting your blood pressure taken, here your blood pressure, you have two numbers. You have systolic and then diastolic. I remember diastolic, D for denominator. So you get these two values. So maybe they're connected. Maybe your systolic blood pressure and diastolic pressure, if one is high and the other one's also high, then they could also really impact cardiovascular risk. So it's just looking and seeing, like, does being a current smoker and cigarettes per day, do they both have the same influences? If you're a current smoker, yes or no, that's what this is asking. And this one is just asking, how many cigarettes a day. So if it's 0, you don't smoke. If it's anything 1 plus, then you are a smoker. So this is helping you determine the extent to which you are a smoker. If you have 1 cigarette a day or 10 a day, there's a difference, right? So that's what this is measuring, is like, are you a smoker or not? And this one is measuring, this is also measuring the same thing, but it's measuring the extent to which you could be smoking if you smoke. It's measuring the extent to which you're smoking. And this one is just saying, this one is focused on, hey, is the act of you smoking, does that change your risk for coronary heart disease? And this one is like, it's not just the act of you smoking, it's the number of cigarettes a day you're having. And then diabetes and glucose, there could be a connection between those, right? Glucose levels and diabetes. And then from that, they drop education, and they figure out which variables to drop because they may not be informative. Then they try to identify the features. So this is what one person has done, Laurie Ann Wu. So they have these competitions, Rex, that are machine learning competition, like who can come up with the best model. Like in the AlphaFold video on the protein folding, I was showing you which convolutional neural network, which deep learning approach, which method had the highest accuracy in terms of predicting if this is the protein structure and shape. So similarly, they have these competitions, and I showed you one model with serum cholesterol or total cholesterol. I showed you another one with 6 different variables, the complex model here. So I showed you these different models. Like there's one for logistic regression I showed you with like systolic, diastolic blood pressure, serum cholesterol, age, BMI, gender. And then I showed you a simple one, which is just serum cholesterol level. I could have also included diabetes risk. I could have shown glucose. I could include so many predictors. But what happens is sometimes it gets too complex and it could be very overfit. But here they're trying to figure out which features do we use? Which features? And they're using some different methods to try to rank the features to put into the model. And these people, their score says, hey, you know, they ran some scores here. They ran some different models, select K-best. These are all different algorithms that people design to help you choose which one is great at helping you predict coronary heart disease risk. So this person's approach, you can choose so many different ways to go about the same question. So they are saying systolic blood pressure has the highest score. So I'll go with that. Which one has the second highest score? And based on that, then what they do is then glucose is the second predictor, and so on. And then they're figuring out the feature importance, like which features do you want to include in your final model as well. And these are the rankings, you know, the systolic blood pressure, then there's glucose. These are the rankings. They just basically plotted this information here, the score. They sort of plotted this information as an importance, you know, like around 600-ish. That's sort of 667. Systolic blood pressure is here, and that's like around 667. So they just sort of plotted the features and then the importance levels. And then they can figure out if you want to keep those features with strong connections with the output, then you use systolic blood pressure, glucose, age, cholesterol, which is cholesterol, and which is total cholesterol, or serum cholesterol. It's the same thing. Cigarettes per day, diastolic blood pressure, hypertensive, which is prevalent hypertension, diabetes, blood pressure medications, and gender. So these are the predictive variables that they decided to use with just the ones that made sense. So, you know, the systolic is here, glucose, age, total cholesterol, you know, cigarettes per day, diastolic blood pressure. So all of those they included, as well as this is the outcome that you're trying to predict. This is the why, the 10-year coronary heart disease. That's what they're trying to predict. And then you can see the correlation as well. And you can see all these variables, how they are connected as well. And these are just some exploratory data analyses of, you know, these visualizations. And you can sort of see how each of these variables is connected with the prevalence of hypertension, diabetes, BP medications. You can sort of see how they are connected with the overall outcomes. So this is not having CHD, this is having CHD as well. You know, those are the outcomes here. You have these box plots as well. And you do some feature scaling. So you are scaling the features as well. So they're using some distance measures. So they're scaling them so that, like, if some variables are like glucose or age, or it could be on a wider scale than others. You know, if you look at the data here, then diastolic blood pressure is on, like, you know, like 70s and 80s, and age is, but total cholesterol can even be like in the 300, 400s, and age can't be up to 400. It's, you know, usually up to like 120, for instance. It's not so high. But in this study, it's like up to 70 because they followed them over 20 years, beginning in the 30s and 50s. So its age is not going to ever be as high as serum cholesterol level, but so they want to sort of scale it so that maybe if they're using some distance metric, total cholesterol doesn't really have more of an impact than age does. So they're doing some feature scaling as well, using some, and then they're doing some outcomes as well, heart disease, patient count, people who have heart disease versus those who don't. They're using some various samples and approaches, logistic regression model, and then they have a confusion matrix. So these are the people who don't have CHD who were correctly predicted. So these are the true negative count. These are the true positives. You know, the positive is usually the one positive, is usually the one class, and the negative is usually the 0. So that means no CHD, and positive means CHD. So that's what that's what those are meaning. This is a confusion matrix for this. So people who don't have CHD, who are correctly identified number of people. These are people who have a CHD who are correctly predicted, and then these are the errors. So these are the errors. And then they can use it to get accuracy for their models, F1 scores, K nearest neighbors. And then they usually get accuracy, F1, precision, recall. So what I'll talk about in decision curve analysis is that these are different approaches. So oftentimes to get the accuracy, for instance, you're going to take the correct ones, which is 534 plus 66. Those are the accuracies. Then you're going to divide this fraction by the total, which is 534 plus 99 plus 51 plus 66. So that's how you get accuracy. Like that will give you accuracy equals, because the ones that are great is when it's 0 and you predict 0, and this is 1 and you predict 1. This is the truth. This is a confusion matrix, the truth and the predictions. So if you predict 0 and it's actually a 1, then this is called a false negative, and this is called a false positive, because when you predict, basically when you predict 1, so that's positive, that's negative, that's positive, and that's negative. So you always look here and you see if it's a false negative, then what you did is you predicted that it's negative, that it's 0, but it actually is positive. So that's a mistake that you made there. That's not good. Kind of unhappy about that mistake. And similarly here, if you're predicting that it's positive, but it actually is negative, then it's a false positive. So for your accuracy, you sort of just add up everything together, and your denominator is everything, and your numerator is the ones that are the positives. This is the true negative, because you actually predicted negative and it's negative, and then this is the true positive. You predict positive and it actually is positive. So this negative is always what your prediction is. It's always like what your prediction is. And it's like, how is your prediction? Is your prediction true or false? If your prediction is negative, then how was it overall? Is it an error? You know, that's what you're sort of seeing. It's always a negative, and like that's what this second part is, the prediction. And the first part is how accurate is that prediction? That's basically how you interpret it. If it's correct, it's a true negative. If it's incorrect, it's a false negative. So if your prediction is negative, you see you can have true negatives and false negatives. If your prediction is positive, you can have false positives and true positives. And these are the mistakes. The mistakes are like, you know, the false positives and false negatives. And then the accuracy is basically the number of correct results, which is true negatives and true positives, divided by all the outcomes. So that's how you find that. And there are other methods like, you know, recall, F1 score, precision. So basically, I just sort of wanted to show you how there are different predictive models out there. And, you know, it's just sort of like how you want to go about coming up with your approach and then evaluating your predictive models. And again, you're going to see that they have so many different approaches to, see your area under the curve, 0.708. You also have like scores for that. You have cross-validation scores. You have accuracies of those models, 83.73, accuracy scores of the test data, train data. But sometimes they don't often tell you like how many of each type of mistake is made. And sometimes false positives and false negatives can have very, very different outcomes. So we can always compare these models and see what is for the decision tree classifier, what is the accuracy, what is the F1 score? The accuracy is not that great, it's 70%. Precision score, recall score, but this is still better than 50% accuracy, which is half the time, because you could either have CHD or not have it. So half the time, if I just 50% random guessing, that's what we're comparing it to. So it is still a pretty good improvement, but we would like it to be like with almost 100%, which is not possible, but in the 90s would be great. So there are different ways to compare models. And that's what I also want to talk about, that there are other metrics to evaluate models, like decision curve analysis, especially in medical decision making. So thank you.